In this lecture, we're going to look at the joints of the upper limb. So we'll look at their articulations, we'll look at the ligaments that support the joints, and then we'll look at some of the movements that are capable of being performed at these joints. We'll look at the sternoclavicular, the acromioclavicular, the glenohumeral and the elbow joints. We'll look at the proximal and distal radio-ulnar joints. We'll then look at the wrist, carpal, carpo-metacarpal, metacarpophalangeal and interphalangeal joints. We'll look at these last few joints all together, really, as the joints of the hand. So let's start with the sternoclavicular joints. And on the screen we can see an anterior view of the sternoclavicular joint that is occurring between the sternum, which we can see here in the midline, and the two clavicles, the sternal ends of the clavicles. Now, the joint capsule, around all of these joints there's going to be a joint capsule. For this one, it actually contains an articular disc. So here we can see the sternal end of the clavicle, here we can see the articular surface of the sternum, specifically the manubrium of the sternum. The manubrium of the sternum, remember, is the most superior part. And within the joint capsule, there is an articular disc. And this separates the capsule into two. The articular disc is important as a shock absorber. Remember, the clavicle is the only attachment of the upper limb, the superior appendicular skeleton, to the axial skeleton. So it can transmit a quite heavy load of force. Attached to the anterior and posterior sternoclavicular ligaments, we can see we've got the anterior sternoclavicular ligament here. On the posterior side, there'll be a posterior sternoclavicular ligament, and this shock absorber, this articular disc, is attached to them via the joint capsule. This is a very strong joint, an incredibly strong joint, and in fact the clavicle is more prone to breaking than this joint being dislocated, a very strong joint. We can then return to the anterior and posterior sternoclavicular ligaments, which we can see here, the anterior. So here we've got a section through the joint capsule, and here we're just looking at it as if it was intact. We've got the anterior sternoclavicular joint, and this reinforces the joint capsule. Superiorly here, the joint is reinforced by the interclavicular ligament, and this helps to hold the two sternal ends of the clavicle to the manubrium of the sternum. So a very solid joint. We also have the costoclavicular ligament, and here we can see the costoclavicular ligament. It connects the sternal end of the clavicle to the first rib. So here we can see the first rib coming away here, and connecting the first rib to the sternal end of the clavicle is the costoclavicular ligament. And this prevents excessive superior movement of the clavicle. The first rib is relatively static, so this will anchor superior movement of the clavicle. Movements at the sternoclavicular joint are multiple. It can be moved in multiple directions. It can move anteriorly, posteriorly, inferiorly, and also a limited degree of superior movement. Now let's move over to another joint, the acromioclavicular joint. The acromioclavicular joint is between the acromion of the scapula to the clavicle. We've got the acromioclavicular joint here, and this is stabilized by a number of ligaments. So the joint capsule, we can see the joint capsule of the acromioclavicular joint here contains a small wedge-shaped articular disc, and the acromioclavicular ligament reinforces the joint superiorly. So here we can see the acromioclavicular joint, and we can see the acromioclavicular ligament, and that is reinforcing the joint. This acromioclavicular joint is supported by the coracoacromial ligament, and this prevents the acromion from passing deep to the clavicle. So here we have the clavicle here, and here we have the acromion, and here we have the coracoid process. And running between the coracoid process to the acromion is the coracoacromial ligament, and this prevents the acromion here passing deep underneath the clavicle. It helps to stabilize, again, this acromioclavicular joint. We also have the coracoclavicular ligament. And the coracoclavicular ligament, as its name suggests, reinforces this acromioclavicular joint again, but is running from the coracoid process to the clavicle. And there's actually two parts of it. The coracoclavicular ligament. It anchors the clavicle to the coracoid process and augments, it supports the acromioclavicular joint. The two parts to it are the conoid ligament. We can see the conoid ligament passing away here, passing medially from the coracoid process, passing towards the clavicle. And here we've got the coracoclavicular ligament again. We've got the trapezoid ligament. We've got the second part of the coracoclavicular ligament. And these two parts, the conoid ligament, the trapezoid ligament, you should remember their features on the inferior surface of the clavicle that we pointed out. These two parts, the conoid and the trapezoid, help to reinforce, help to augment the acromioclavicular joint. Movements at this joint, we have rotation on the acromial end of the clavicle, and this is due to the contraction of the thoracoappendicular muscles. Muscles that are passing from the thorax to the appendicular skeleton. These can move the upper limb at this acromioclavicular joint, and we can have rotation, so forward, backward, lateral rotation as some of the movements that are possible. So now we're going to look at the glenohumeral joint, or the shoulder joint, between the head of the humerus and the glenoid cavity, or the glenoid fossa on the head of the scapula. And we can see on the screen we've got numerous images which show different views of this joint. So here we can see a section through the joint. We can see we've got the head of the humerus here, and we've got the glenoid cavity. We can see the shallow glenoid cavity and the relatively large head of the humerus. Here we can see a lateral view. We can see the glenoid cavity and how it's deepened via this glenoid labrum. And then we can see some of the ligaments that are helping to support this joint. So if we look at the articulation, then as I mentioned, we have this large humeral head, but it's running up against this shallow glenoid cavity. Now, although this allows increased range of movement, it means there's reduced stability. So when we look at the hip joint in the lower limb lectures, you'll see that the equivalent of the glenoid cavity, the acetabulum, is very deep, and it actually holds the vast majority of the head of the femur. Here, we've only got a very shallow glenoid cavity for that large humeral head. The glenoid cavity is reinforced, it's deepened by this fibrocartilaginous glenoid labrum. We can see the glenoid labrum here. We can see it running all the way around the glenoid cavity, and this serves to deepen that recess which the head of the humerus sits. We can see we've got the glenoid labrum running around here, helping to deepen that cavity. The humeral head is held in the cavity, if you remember, by the tonic contraction of the rotator cuff muscles. These scapulohumeral muscles passing from the scapula to the humerus, the supraspinatus, infraspinatus, subscapularis and teres minor muscles, the basal contraction, the tonic contraction of these muscles actually pulls the head against the glenoid cavity, and this actually helps to stabilize the joint. The fibrous capsule of the glenohumeral joint is relatively loose. This allows the increased mobility. If it was tight, then you wouldn't have as much mobility. And it's running from the glenoid cavity to the anatomical neck of the humerus. So we can see we've got the anatomical neck of the humerus here. Remember, it's between the tubercles of the humerus and the surgical neck and the head, the anatomical neck between the tubercles and the head of the humerus, and it attaches here to the perimeter of the glenoid cavity. Superiorly, the joint is actually reinforced because we have the tendon of long head of biceps. And here we can see the tendon of long head of biceps. Remember, it's passing through the intertubercular sulcus, the intertubercular groove between the two tubercles. It's running up over the head of the humerus to attach to the supraglenoid tubercle. And this, along with the acromion, helps to reinforce the joint superiorly. Inferiorly, the joint is very loose, and there's no reinforcement inferiorly of the capsule. And if the humerus is to dislocate at the glenohumeral joint, it typically will be an inferior dislocation. The head is then pulled forwards via the action of pectoralis major and muscles. So let's have a look at the ligaments to support it. Well, we have the glenohumeral ligaments. The glenohumeral ligaments we can see here are found anteriorly, and they strengthen the joint anteriorly. We can see we've got superior, a medium, and an inferior part of the glenohumeral ligament, and these are running here. Here we can see the tendon of subscapularis passing to the lesser tubercle, one of the rotator cuff muscles, and that will be coming from the subscapular fossa. Here we can see the anterior view of the joint, so we can see the coracoid process here as well. But here we have the glenohumeral ligaments, superior, medium, and inferior, we can see lying anteriorly to reinforce the joint. We also have the coracohumeral ligament. The coracohumeral ligament passes from the coracoid process to the greater tubercle of the humerus. And this is a strong band. It strengthens the joint again superiorly. So we can see the coracohumeral joint running across here to the coracoid process, and it passes to the greater tubercle of the humerus. It strengthens it superiorly. We also have the transverse humeral ligament, and this bridges the intertubercular groove. It attaches to the greater and lesser tubercles, so we can see it running over here. And it creates that tunnel for the long head of biceps to pass through. We also have a complex arrangement that, again, is very strong, and it prevents superior dislocation. And this is known as the coracoacromial arch. We have the coracoid process, we have the acromion, and we have the coracoacromial ligament. Remember, the coracoacromial ligament helping to augment, support the acromioclavicular joint. Well, it actually forms a roof over the superior aspect of the glenohumeral joint, and this serves to prevent superior dislocation. Movements at the glenohumeral joint are flexion, extension, abduction, adduction. We've got rotation, and we've also got circumduction. And these movements cover a wide range, and they're possible due to the high number of muscles that enable these movements, and also the loose fibrous capsule and the arrangement of the head of the humerus onto the glenoid cavity. These allow a high range of movements. Now let's move on to the elbow joint and the articulation of the elbow joint. We have two articulations with the elbow joints, with the humerus articulating with both the radius and the ulna. And here we can see the anterior view of that joint with the with the bones pulled apart to expose their articular surfaces. We can see we have the humerus here. We can see laterally we have the capitulum of the humerus, and that is going to articulate with the head of the radius. So the head of the radius is going to sit against the capitulum of the humerus. We then have the trochlea of the humerus, which we can see here, and then remember we have that C-shaped trochlear notch. We have the C-shaped trochlear notch that sits in this barrel-shaped trochlea. And these articulations allow flexion and extension to occur. The joint capsule around the joint surrounds the elbow joint and attaches to the edges of the articular surfaces. So it's going to be running around these articular surfaces here. It can in fact cover both the coronoid fossa, which we can see here. This is the coronoid process, and with full flexion, the coronoid process would sit in the coronoid fossa. The joint capsule will just go over there, so these articulations occur within the joint capsule, and it'll also, as we'll see, go over the olecranon fossa. And we can see that on this diagram here. Anteriorly, we can see the anterior view. Here we can see the medial epicondyle, and we see the lateral epicondyle, and we can see that the joint capsule is covering what would be the coronoid fossa here. Here with the coronoid process of the ulna. And posteriorly we can see we've got the olecranon fossa, and the joint capsule is covering that olecranon fossa where it would house the olecranon of the ulna. So we can see we've got the joint capsule running over the elbow joint. If we look at the ligaments that help to support the elbow joint, then we have a number of what are called collateral ligaments. And these are strong bands that reinforce the lateral aspect of the joint, that reinforce the lateral aspect of the joint. And they're these lateral thickenings. We have the ulnar collateral ligament and we have the radial collateral ligament. The ulnar side we can see here, we've got the ulnar and we've got the medial epicondyle, and here we can see the ulnar collateral ligaments. These are triangular shaped ligaments that are coming from the medial epicondyle of the humerus and passing to the coronoid process, and they're passing to the olecranon. We can see them passing to the coronoid process anteriorly and then sweeping posteriorly, medial epicondyle, we can see them coming around onto the olecranon. These are your ulnar collateral ligaments, and these help to reinforce the joint. We have radial, and these are fan-like. We can see them on this radial side. Here's the radius, and we've got this radial collateral ligament. It's coming from the lateral epicondyle, and it actually blends with a ligament known as the annular ligament, and that runs around the head of the radius. But these two collateral ligaments, these strong bands that reinforce primarily the lateral aspect of the joint, the ulnar and the radial collateral ligaments. The annular ligament, this encircles the head of the radius, and that is primarily involved in the proximal radio-ulnar joint, which we'll have a look at in a moment. But this joint allows flexion and extension to occur, and the joint capsule permits those movements between the capitulum and the radial head and the trochlea and the trochlear notch. So if we have a look at the radio-ulnar joint, the proximal radio-ulnar joint, then we can see the articulation is going to between the head of the radius here and the radial notch of the ulna. The joint capsule is continuous with the elbows. So the elbow joint capsule covers this joint as well. And we can see we have the annular ligament. This encircles the radial head. We can see it attaches to the anterior and posterior surfaces of the ulna. It's passing all the way around the head. And this enables the radius to just rotate against the ulnar notch, which we can see in here. Sorry, the radial notch, which we can see here on the ulna. And this enables pronation and supination to occur. If we look at the distal radio-ulnar joint, the articulation of the distal radio-ulnar joint, again, is between the head of the ulna and the ulnar notch on the radius. So we can see we've got the head of the ulna here in this section through the wrist joint to see it. We've got the head of the ulna, and then we can see we have the ulnar notch on the radius here. And this connection would be your distal radio-ulnar joint. Your distal radial-ulnar joint. We have a small articular disc that binds the joint together. So we've got the joint capsule coming around on the wrist, and we've got this articular disc that's binding, that's holding the joint together. We can see the articular disc has been slightly reflected here, and now we can see into this distal radial-ulnar joint here. The articular disc attaches to the medial ulnar notch of the radius, so we can see it's attaching here, and then it runs over and attaches to the styloid process of the ulna. And this enables this L-shaped joint cavity to be formed. This L-shaped joint cavity to be formed. The ligaments, anterior and posterior ligaments, support the distal radio-ulnar joint, and they strengthen the joint capsule. So we have ligaments on both the anterior side and the posterior side running over here and then running underneath here. And these help to support the joint capsule. Like the proximal radioulnar joint, the distal radioulnar joint is involved in pronation and supination. If we then move on to the wrist joint, the articulation of the wrist is between the radius and the proximal row of carpal bones. So here we can see the radius. This is a dorsal view of the radius. The ulnar doesn't articulate with the carpal bones. It's the radius that articulates with the carpal bones, and specifically the proximal row of carpal bones, not including the pisiform. So we can see we've got the radius here. We can see we have a whole number of ligaments. We've got anterior and posterior ligaments that these serve to strengthen the joint capsule. So we can see we have a dorsal radiocarpal ligament here on the dorsal surface. We'll also have a ventral one on the anterior surface running from the radius to the carpals, and these help to reinforce these joints. We also have our collateral ligaments once again, and these are on the ulnar side and on the radial side. So here we have the ulnar collateral ligament running from the ulnar styloid process to the triquetrum, one of the carpal bones. And here we have on the radial side, we have the radial collateral ligament reinforcing the fibrous joint capsule that is running from the radial styloid process to the scaphoid bone. And these are holding the bones together in place, allowing their articular surfaces to come together. What movements can occur at this joint? Where we have flexion, extension, abduction and adduction, and we also have circumduction. So these movements are able to occur at the wrist joint. Now let's move on to the joints of the hand specifically, and a whole series of joints within the carpal bones. We can see here we have the carpal bones, we have the scaphoid, we have the lunate, we have the triquetrum, we have the various carpal bones we can see here in this section through the hand and the wrist joint. We can see the wrist joint here, we can see the distal radioulnar joint here. So the articulation between these carpal bones into carpal joints, well, there's numerous anterior and posterior ligaments. There's also interosseous ligaments that you can see connecting the various carpal bones together. And really, there's a lot of them, and they just are sitting in and around the carpal bones. So we have numerous anterior and posterior and interosseous ligaments. Movements that occur with the carpal bones, we have flexion and extension of them, and they also help to augment the movement of the wrist. So carpo-metacarpal, that's the joint between the carpal and the metacarpal bones, and then later on we'll look at intermetacarpal, the joints between the metacarpals. If we have a look at the articulation between the carpal and the metacarpal bones, again, we have numerous ligaments, anterior and posterior and interosseous ligaments. We can see interosseous metacarpal ligaments running between the two metacarpals here and here, and here and here, here and here. And we can see we have carpo-metacarpal joints, the joints between the carpal bones and the metacarpals. Movements, well, at the thumb, we have flexion, extension, abduction, adduction, and circumduction. So here at the thumb's carpo-metacarpal joints, we have a whole range of movements. But for the fifth digit, we really just have flexion and rotation. Now let's look at the joints of the digits, the metacarpophalangeal joints. Articulation is the head of the metacarpals with the base of the proximal phalanges. So here we can see the metacarpal, and here we can see the proximal phalanx. So here we've got the metacarpophalangeal joint. And these are going to be reinforced by strong palmar ligaments, which we can see here running from the metacarpals to the phalanges. And we can also see we have some collateral ligaments that are running alongside the metacarpophalangeal joints. These are collateral ligaments running either side of the metacarpophalangeal joints. running from the heads of the metacarpals to the bases of the phalanges. We then have interphalangeal joints, where again we can see some tough palmar ligaments here, and again we have some collateral ligaments. And the interphalangeal joints, the articulations, are between the heads of the phalanges with the base of the more distal phalanx. So the ligaments, here we can see we've got strong palmar ligaments here. We can see we've got collateral ligaments that are this time between the phalanges. So we've got collateral ligaments here, another collateral ligament here, and you can see we've got some strong palmar ligaments. Movements that occur at the metacarpophalangeal joints and the interphalangeal joints we'll see down here at the bottom. The metacarpophalangeal joints, we have flexion and extension, we have abduction and adduction, and we have some circumduction. Only flexion and extension of the metacarpophalangeal joints occur at the thumb. At the interphalangeal joint, we have flexion and extension. The only movements that are allowed to occur at the interphalangeal joints are flexion and extension. So in this lecture, we've looked at a whole series of joints associated with the upper limb. We've looked at the sternoclavicular joint between the manubrium of the sternum and the sternal end of the clavicle. We've looked at the acromioclavicular joint between the acromion of the scapula and the acromial end of the clavicle. We've looked at the glenohumeral joints between the scapula and the humerus, and then we looked at the multiple joints associated with the elbow. We looked at the proximal and distal radio-ulnar joints between the radius and the ulna. We then looked at multiple joints within the wrist, including the distal radius with the proximal row of carpal bones. And then we looked at the carpal joints, carpometacarpal, metacarpophalangeal, and interphalangeal joints.